Welcome everybody to UW TelePain. Jim Robinson will be speaking today, so I'm going to moderate. This is Mark Sullivan, and we're going to start off today with a didactic session by Jim Robinson on exercise therapy for chronic back pain. And we have a couple of cases to review, so please stay tuned. But first, Jim is going to talk about exercising chronic back pain.
Okay. Well, I actually, this is say part of a larger talk where I do talk about rationales for exercise, reason why physical therapy often fails, and then some behavioral principles in physical therapy. I'm really not going to get to the two first subjects because there won't be time, but just say there are many good reasons why we want our patients with chronic musculoskeletal problems to exercise. I'll just leave it at that as sort of a, prima facie case that exercise is good for our people, and rather than give you a whole list of rationales, just bottom line is good. As far as reasons for failure, I think there are multiple reasons why physical therapy fails, and obliquely I'll be talking about some of those. I think that there are certainly patient factors that contribute. I think there are physical therapist factors that contribute, and I think there are clinician or physician or whoever is actually directing the physical therapy or ordering the physical therapy. I think that they can also contribute to failures, and again I'll get back to that as we go on. But I do want to talk about, really focus on behavioral principles in physical therapy. And just by way of preface, I say physical therapy. What we really want is for patients to exercise on a regular basis. Physical therapy is a means toward that end. So I'm going to probably slide back and forth between saying physical therapy and exercise therapy. Just to me, again, the physical therapy is a means to an end. Okay, physical therapists, at least the ones who come to the University of Washington, in my mind, are very smart people, and they get very good training in biomechanical factors. And by the way, this is low back pain, but they really understand biomechanics of the spine. They understand principles of exercise training and so on. They're good biomechanics. Will do some biomechanics wrong. A lot of older people do not tolerate what are called McKenzie exercises, where you have people lie on their stomach and prop themselves up. And so a physical therapist might take a 70-year-old person and give them those types of exercises. I would call that a biomechanical mistake. But that is really the rare exception as far as I'm concerned. Another related point is that there are many exercise therapy programs that can be used for back pain, and all the evidence suggests that there's no evidence that one is better than any other. They're all equivalent. So if you look at research on exercise therapy for back pain, you see that overall it does have beneficial effects on recovery, but always what the studies that show that are always comparing exercise therapy to nothing, exercise therapy to something like that. When they compare exercise therapy type 1 to exercise therapy type 2, they essentially never find that one is better than the other. At least it's not a consistent thing. There's some studies that have shown that McKenzie exercises may be a little bit better for a short period of time in people with back pain than some other approaches, but that's very ephemeral, not always replicated, and certainly not in the long term. I would like to point out a couple of references on this issue of the equally potency of different exercise programs. I'd just like to point out Heather Kroll, who's a physiatrist here in Seattle, has written a very nice review article, and I'll put in a plug because this is from the PM&R Clinics of North America, an issue that I and somebody else edited, came out in May of this year. And Heather, again, found that there is no credible evidence that one exercise program is better than another. So the real big problems, at least that we see in our chronic pain patients, is to get the patient to do anything. I would say another challenge is to get the patient to persist in the face of adversity or in the face of flare-ups. And the third is to get them, even if they go to physical therapy, to internalize this and incorporate exercise into their daily living. And so overall, as far as I'm concerned, those goals there, getting people to do something, getting them to persist, getting them to take responsibility and work on their own, those are behavioral issues. And I would just say overall, in the world of physical therapy, exercise therapy for back pain, behavioral issues are more important than biomechanical ones. So, what is it when we look at behavioral aspects of exercise training for low back pain? I think that there's a huge amount that goes by way of patient education. And I'll get to some of these things: exchange lists, biomechanical rationale for exercises, cardiovascular monitoring, which is sort of interesting because eventually I like my patients to get into cardiovascular good shape. And what I'm stunned, at least at the pain center, it seems to me that more than half the patients I ask cannot tell me how to find their pulse, and they cannot define what an aerobic training exercise is. So it's just stunning how lacking our people are in information. I think that education would include development of strategies for managing flare-ups, and I'm going to get back to that because I think that is a huge problem. And also, education involves setting reasonable expectations that exercise therapy is work, that there will not be some immediate resolution. It takes time. And again, I'm stunned at the patients that I see where they say, well, I went to physical therapy, I went twice and I wasn't better, so I quit. Well, that represents an unrealistic expectation of what you can get out of exercise therapy. Okay, which exercises? We're talking about back pain now. I've taken an analogy with the American Diabetic Association diet, where they have what's called an exchange list. If you like carrots, eat carrots. If you like celery, eat celery. But they're both equivalent from the standpoint of their effects in a diabetic diet. I think we could say an analogous thing in exercise therapy. There are multiple exercises that can produce essentially the same biomechanical effect. And what's important is that if a patient is having trouble with one exercise, you may want to switch and have them do a different exercise that so just flesh this out. These three pictures, what's the common thread here? Somebody showed me triathlon, and I thought, oh no, I never thought of that. But actually, what I thought of as the biological underpinning here is these are all aerobic exercises. From the standpoint of your heart, it doesn't matter whether you swim, bicycle, or run, you get the same cardiovascular effect. These are equivalent exercises in the sense of equivalent from an aerobic training standpoint. And if we look at these two, for example, these would be, in my mind, equivalent exercises for creating flexion, mobility of the lumbar spine in flexion. Again, the point is you can find different exercises that achieve the same goal. So again, back to which exercises, it's better if an exercise can be measured or quantified, because when we talk in a minute about what are called baselines, a baseline refers to an intensity of an exercise that a person can tolerate, at least when they start training. And you can really only use that term if you have something that can be quantified. So I give the example for abdominal strengthening of sit-ups versus isometric abdominal strengthening. Either one of those can strengthen a person's abdominal muscles, but sit-ups can be quantified, so you can say how many sit-ups a person can do at baseline, whereas isometric abdominal exercise is much harder to say exactly how hard are they contracting their muscle at baseline. So getting on to baselines. But by definition, a baseline is a level of intensity of an exercise that a person can tolerate without adverse effects. And basically, if you have exercises that are quantifiable, you want to establish baselines for every exercise in a physical therapy program. And just an aside, over and over again, when I talk to patients at the pain center, many of them have blown out of physical therapy in one visit because what they were asked to do was far beyond what they could do at that time. And so the physical therapists, in their rush to get improvement, will often push people beyond what they can do at the time of beginning of training. And So I would just say this is a key point and a key reason why physical therapy programs often fail. I just spoke to a lady an hour ago who said she spent the whole time crying in her first physical therapy session because she just couldn't do what the therapist was asking her to do without terrible pain. So I'm not sure what actually happened. I'm going to talk with the physical therapist. But this is an example where whatever did happen, baselines were not established. Okay, sometimes it takes a few sessions to really establish a good baseline. In the old days, when we used to have a comprehensive intensive pain rehabilitation program, we would have people do exercises for about 3 days before we really determined what their baseline was. In this world of everything hurried up, that's hard to do now, but at least you have to realize the obvious, that people have good days and bad days, so their capacity for a certain exercise on a certain day may be different from one day to another. Exercise progression. There is no clear-cut formula for exercise progression in a person with a back problem. Let's assume, just to take an example, if a person can do 5 sit-ups at baseline, what would you ask him to do the next time the person comes back, let's say a week later for physical therapy? Well, we don't really know. When we used to do our rehab program, we would set the rate of progression of an exercise. In the real world, outpatient rehab, physical therapy, usually it's patient-determined or sort of determined between the patient and the physical therapist. And I think that's perfectly reasonable. If we as practitioners set this progression, we have more control, but ultimately the control has to go to the patient anyway. So I'm happy to have the patients involved in this issue of progression once a baseline has been established. I suggest a reasonable thing would be to try to get about a 10% increase over baseline in the first week of training, and then see how the patient is doing. If the patient says, that was wimpy, I could have done twice as much, well, that means you can progress faster afterwards. If the patient says, I got a real flare-up, then you really may have to slow down and go at 5% increase per week. The point is that once there are 2 data points, you have a baseline output and you have a amount of output a week later, you now have 2 points on a graph and you can get a sense of what might happen next. So the point is, in the real world, again, when we don't have these comprehensive programs like ours, there's a lot of discussion between the patient and the physical therapist about how to progress. Maximal medical improvement, another basic concept as we think about behavioral principles. Everybody reaches a performance plateau. Nobody runs a 1-minute mile. The patients will reach some point where they don't go beyond that, or if they do, they continue to kind of have setbacks, and so they're thrown backwards rather than forwards. Important thing for our pain patients, maximal medical improvement does not mean when the first twinge of pain occurs. If they stop at that point, that means they'll never start. What they need to do is to establish the maximum they can do. Let's say it's lifting. How much can they lift after a training program? Let's assume they start at 10 pounds. They work up to 40 pounds. But if they go up to 50 pounds, they really have increased discomfort, and so it looks as though maybe 40 pounds is as much as they can lift. My point is they have to try that several times, sort of work around the edge of the cliff, so to speak, a few times before they can really say that a 40-pound limit is really the best for them. Now, this is an example of what we call quota-based exercise, and I've just made this up, but it's basically for a low back pain patient. We're talking about lifting capacity. And unfortunately, there are 3 yellow lines at the left-hand side, and those are meant to refer to baseline sessions. So if you notice, there's a little variability around what the baseline is, but it looks as though the person can do about 10 pounds. Okay? So in the way we did it in a quota-based exercise program, we would then start them in training at less than 10. You want the training to succeed. So you start them below their baseline, but then you gradually ramp up, and finally, in this instance, we get them up to about 45 pounds, and then they level off. But this just gives you an example of how we used to do things when we controlled the progression. In a real patient out in an outpatient physical therapy program, you couldn't draw this graph beforehand. you'd have to, they'd work it out between the therapist and the patient. So ultimately, you want to continue exercise, ideally, if the insurance people will allow it, until the person has reached maximal improvement for specific exercises and for all the exercises in a program. Home monitoring. What we found, again, when we had our intensive program, was that if we gave people graphs and had them fill out how much they were doing, how many minutes they were walking, how many minutes they worked on a bicycle, what their lifting was, we found that this was really reinforcing for them because they could see their progress. A lot of our pain patients would come in and say, nothing has worked for me, nothing will work, this is all useless. And when you say, but look, Mr. Jones, look at how you've improved over the last 2 weeks, it really is a real boost to their confidence. Among other things, graphic things help people remember where they were at baseline, and again, they can see progress, and we found it very motivating for folks. Okay, termination of physical therapy. I would argue, first of all, that, I'll get to success in a minute, but termination, I would say, should occur when their 4 goals have been reached. 1, the person has reached maximal medical improvement in the exercises in the treatment program. 2, that they understand what they're doing. They understand the biomechanical rationale for their exercises. And by the way, ask people when they come back, and my patients rarely can say why they're doing an exercise. They say, I'm doing it because the physical therapist told me. That's not something that is conducive to the patient taking over and being their own self-manager. They need to understand why they're doing something. They need to understand other concepts like exchange lists. They need, in my opinion, strategies to manage flares, and that's, to me, is so central. I'm going to get back to it. And they need a commitment to a home program. So to me, those are the 4 goals that you'd want people to accomplish by the end of a physical therapy program. So when does a physical therapy program successful? I would say it is successful if the person has achieved the 4 goals, just on the last slide. A key point is success in physical therapy does not mean full recovery. And I think we as clinicians often confuse those two. We say the person has failed physical therapy because they still haven't gone back to work. Well, not so. They may have accomplished the 4 goals that I just outlined. And if they have done that, then we should say, okay, they have succeeded in physical therapy. They still may be, not as functional as we want them to be, but let's not blame the physical therapy. It is important, though, not to accept the patient's global assessment. When they say physical therapy failed, it's really important to say, well, what did you do in therapy? Which goals did you accomplish? And so on, to sort of deconstruct this issue of physical therapy failed. But on the other hand, if a person has achieved all the goals, to not keep sending them back to physical therapy. I'm guilty of this, I'm sure, but a lot of times we as clinicians send people back to physical therapy over and over again because we don't know what else to do. And the person has gotten as much as they're going to get out of physical therapy. They have put their heart and soul into it. They're doing what they can. Let's say, good for you, Mr. Jones. You've succeeded in physical therapy. Let's see what else you need. Okay, practical strategies. I think it is important to get to know some physical therapists because it's really that kind of personal relationship with therapists that are important. As far as orders go, question of how specific, and Walter Stoloff is sitting here today, and he was the champion of very specific orders, and I as a resident wrote them. I don't do that so much anymore, and I think in the well, we get the accolades from the sideline here, but I think particularly for a primary care provider, I'd say general orders are reasonable, but they have to be emphasizing active physical therapy. However, there's a flip side. There's a way of making things more specific, and that is that you follow up with the physical therapist, you follow up with the patient. And in particularly, I put this backwards, following up with the patient is the first step. Once people start physical therapy, you need to interact with them. You need to find out what they did in physical therapy. You need to have them demonstrate the exercises. Then, as in that once you see what started in physical therapy, you can work on fine-tuning it. And I would just say this is absolutely crucial. Again, number 3 and 4 there, or number 2 and 3. Ask about how it's going, have the patient demonstrate the exercises, then get back to the physical therapist and say, you know, it looks as though Mr. Jones is really not tolerating the sit-ups at all. Why don't we think about some different way to get the abdominal strengthening done? So you can become more specific and work with your physical therapist on more specific of an exercise program after you've had some interaction with the patient. So I jumped ahead and I said, before you ever start, because this slide is about interactions with patients, so you start by educating the patient before they go to physical therapy. What I do, I've written a paper on exercise therapy for back pain, so I will email the patient a copy of that and go over it with them before they go to physical therapy, because so many of our patients have failed before, and I don't want to just send them back and have another guaranteed failure experience. So again, educate the patient beforehand, ask about progress, have them demonstrate exercise, and again, don't accept the global assessment. If the patient says PT hurts or PT is failing, you have to deconstruct that, find exactly what's going on, then you can figure out pathways to success. And another thing, practical strategies for interacting with patients, manage flare-ups. I'm going to get to that in a minute. Okay, flare-ups. Most patients, at least that I see at the pain center, will have flare-ups. I think most back pain patients do. The best evidence we have is that the likelihood of any serious injury in an exercise program for low back pain is very low. That's the best data we have. But what will happen over and over again is the patient saying, well, the therapy made me worse. And I would argue that when people experience increased discomfort in an exercise program, it's not easy to assess. It's hard for the patient to assess it, it's hard for the physical therapist, and it's hard for the clinician. These are not easy things. It's those flare-ups that often lead people to quit. And again, to me, flare-ups are the Achilles heel of any attempt to restore function in people with chronic back problems. And this is what we found in our comprehensive rehab program. The people would go through the program and look good, but then they would have a flare-up 2 weeks after being discharged, and it's like they'd forget everything. They'd be absolutely seemingly back to square one because they didn't know how to manage a flare-up. The patients will panic and overgeneralize. When things go bad, they'll say everything is horrible. So I think that in terms of what, and I believe that you as a clinician can really help the patient work through a flare-up by being analytical. Don't just throw up your hands just the way the patient did. So first question is, did the flare-up result from the exercise program? Maybe there's some totally different reason. If so, which exercise is the culprit? And it's helpful if you know the biomechanics of different exercises. That'll give you some ideas. But at least you can have the patient show you the exercises and let them tell you which ones they're having trouble with. What I do, again, taking an analogy from the diet literature, is, well, I'll call it an elimination diet, where if the patient says, you know, it is those hyperextension exercises that are just killing me, I say, okay, don't do those for a week and let's see what happens to your pain. So the idea is you can isolate which aspect of the physical therapy program is bothering them by having them drop one exercise but keep everything else going. Okay, let's assume you've identified what looks to be the offending exercise. Then you have other questions. How important is this exercise? Are there possibilities for exchange? Can you get the same biological, biomechanical effect using a different exercise? I would distinguish between, in terms of whether to push through pain, I think it does depend on what type of exercise we're talking about. I think for aerobics and strengthening, I think that no pain, no gain is at least sort of okay. At least a little pain is okay. I would say it's different in my mind for stretching. If a person stretches and they hurt, they're going to just tighten up and that's going to defeat the stretching. I also don't think skill building occurs very well when a person is hurting. So think about, again, how important is the exercise? Can you find a different exercise that includes the same goal? And what is a type of exercise? What is the severity of the flare-up? You know, what are the functional consequences? Is it just a person says, I hurt a little bit more, or are they now in bed? Are there associated clinical findings that give you some hint that there really has been some biological insult. Do you do a medical workup? In other words, if a patient, for example, is in an exercise program and now they're getting sciatica type pain, you may need to do an MRI scan. Are you going to do anything that sort of supports them, a sort of palliative care to help them continue in their exercise? Medications, injections, massage. What are you going to tell them to do about the exercise? Push ahead, tough it out, reduce the intensity, pick a different exercise, drop that entire type of exercise. All of these are decisions that are important for you to work with the patient on. I think that as you go through this, you're giving messages to the patient. One is the difference between hurt and harm, and the idea that increases in pain are not fun, nobody wants them, but that's different from serious harm. And if your patient is really philosophically inclined, has gone the training that Mark Sullivan has undergone as a PhD philosopher, they would understand that pain is actually an opportunity on how their body works, allows them to make adaptive changes. Not too many of our pain patients are quite ready to accept that perspective, however. I think a thing is to have the patient stay calm. The catastrophizing is the enemy here. They have to be analytic, keep their emotions in check, try to figure out what caused the problem, what the strategies they have, and if you kind of work with them in a systematic approach, that hopefully gives them the skills that they can do that themselves in the future. So overall, to summarize, behavioral principles, a lot of the things I've talked about were actually developed in the context of the comprehensive rehab programs that we've used to have here at the university. To implement these principles is very time-consuming, and I'm sure those of you in primary practice with 10 to 15 minutes to spend with a patient, it's hard to have them review their exercise program and to work with them on strategies. But I would say if you don't do that, physical therapy is going to fail. So I will stop there.
Thank you, Jim. Before we proceed, it looks like we have a couple of questions. And from Catherine Henderson, she asks, how do you improve baseline if baseline is 0?
Send them to outer space so gravity is eliminated. I have trouble accepting the 0 base. Some patients are horribly incapacitated. I will buy that. But even those people transfer out of bed. They do make it to the bathroom or to some toilet. They do feed themselves. So I would say that in severely incapacitated people, by the way, I switch from a focus on, let's say, baselines and therapeutic exercise to a more basic thing of function and activities of daily living. And so then you can sort of get a different baseline. You know, can you transfer from a bed that is 36 inches high to a standing position? Maybe you need to start with a bed that's 40 inches high, and so on. So, but the notion that baselines are 0, if they were 0, the person, it would be basically like you're in a coma. Everybody has a baseline that's greater than 0.